And without further ado, I'm excited to announce our wonderful speaker today, Dr. Sara Lewin, who's an associate professor in the Division of Gastroenterology here at UCSF. And she's a UCSF lifer. It sounds like med student residence. She specializes in IBD and nutritional deficiencies and disorders in patients with inflammatory bowel disease. So really excited to have you here. And I'll let her take it away.
All right, so thank you everybody who's here on Zoom and here in the live audience, and thank you again to Dr. Wachter and to Dr. Bond for inviting me to speak here today. I'm really excited to be here. It's really a great honor. So my talk today is about the advances in care for hospitalized patients with inflammatory bowel disease, which is my area of clinical research interest as well as clinical interest. It's a nice intersection in my role as the director of the inpatient consult service here at UCSF Health, as well as caring for our outpatients with inflammatory bowel disease. These are my disclosures. And our learning objectives for today are to identify quality metrics that can be utilized in the care of hospitalized patients with inflammatory bowel disease, and then also to identify novel therapeutic approaches in the management of inpatient IBD. I could spend the whole time here talking about all the new novel therapeutics that have come out in the decade since I have been in training, which includes basically, I think, at least 10 new drugs that are FDA approved for the treatment of Crohn's and ulcerative colitis. But I will not be focusing on the nuances of each of these different drugs today, and then we'll be more focusing on the inpatient care, where these drugs are not as heavily utilized, in part because of most of them, their slow onset of action. In terms of some fast facts, just to remind ourselves, approximately 2.5 million Americans have inflammatory bowel disease. And although we typically think of inflammatory bowel disease as an ambulatory condition, up to 1/4 of patients with ulcerative colitis will require hospitalization at some point during their lifetime. And for Crohn's disease patients, that number is up to 80% of those patients will require hospitalization. The reasons for hospitalization are many, but mostly include severe disease flares, but can also include things like toxic megacolon, failure of outpatient medical therapy, complications of their disease, such as venous thromboembolism, complications related to medical therapy, for example, opportunistic infections for patients who are immunosuppressed, and severe extraintestinal manifestations such as pyoderma gangrenosum flare. For the purposes of our talk today, I will be focusing really on the severe disease flare and inflammatory bowel disease. And so when we think about why these patients are hospitalized, for ulcerative colitis, it's much more homogeneous. For severe disease flare, typically is related to either severe or fulminant colitis. And that can be characterized by the True-Levin-Witz criteria, which looks at factors such as the number of bowel movements per day, and then other markers of systemic inflammation, such as tachycardia, anemia, elevated inflammatory markers, and even more of a sort of sepsis-type physiology with fever, abdominal pain, et cetera. In Crohn's disease, you can also have a similar phenotype with a severe enterocolitis flare that can be characterized similarly in terms of the number of bowel movements per day, pain, inflammatory response. And this is managed very similarly to severe ulcerative colitis. So we kind of put that into the same bucket. In contrast with Crohn's disease, because of its transmural inflammation nature and its ability to have penetrating disease and stricturing disease, we can also have care for hospitalized patients with Crohn's disease with small bowel obstruction, either related to inflammation or related to fibrostenotic strictures, and then a new myriad of different infectious complications from either perianal or intra-abdominal enterocutaneous fistulas and abscesses. The management of which is much more about kind of acutely treating the complication acutely, whether it's a bowel obstruction or infectious management of an abscess. Regardless of what the overall treatment plan is, there are well-established high-quality care principles for the care of these patients. And these include assessment of disease severity and extent, performing an appropriate diagnostic evaluation, preparing for and providing appropriate medical therapy, and we'll go through some of the nuances of that, prevention of complications, nutrition, and appropriate timing of surgical consultation. So we'll go through each of these different categories to review some of these quality metrics that we really should be adhering to when caring for these patients. And I think about this as a lot that has to happen on day one. So it's a very upfront, heavy intervention that we have to do for these patients. And then they often will stay on average for about a week when they come in for inflammatory bowel disease flare. But for day one, the first thing that we need to do is assess the disease severity and extent, and this will give us a benchmark to follow throughout the hospitalization. So for ulcerative colitis, there are a number of scores, but I find the Simple Colitis Disease Activity Index, which looks at factors such as bowel frequency and urgency and pain, and Harvey-Bradshaw Index, which also looks at things like abdominal pain, the presence of extraintestinal manifestations. And we can follow this longitudinally day by day throughout the hospitalization, but to get a benchmark is an important first step. It's also very busy right at the get-go, maybe not day one exactly, but day 1.5 perhaps, in terms of diagnostic evaluation that needs to happen. So with laboratory studies from a blood standpoint, getting a full panel, including a CBC, a complete metabolic panel, iron studies, inflammatory markers, and then micronutrient screening with vitamin D and vitamin B12, and then a pregnancy test if applicable, as that may have implications for what therapies are available to patients. We also recommend stool studies universally, in particular, screening for infections, as well as getting a marker of inflammation at baseline with a fecal calprotectin. And then some kind of imaging, at the very minimum, an abdominal X-ray or cross-sectional imaging. And the abdominal X-ray at the very least can look for signs of obstruction, signs of impending toxic megacolon. So again, to establish a baseline at which we can follow throughout the hospital stay. And then lastly, in many patients, flexible sigmoidoscopy or colonoscopy is important to not only ensure that we have truly and adequately assessed the disease severity and extent. Certainly it's possible someone could be reporting 8 to 10 bowel movements per day, but the etiology is actually not their inflammatory bowel disease. So getting an endoscopic correlate is very important, as well as getting biopsies to look for things like cytomegalovirus infection, which can only really be detected on endoscopy. And another thing that really should be happening on day one as well is initiation of appropriate treatment. And so we think about corticosteroids for treatment for severe inflammatory bowel disease flares. Those we typically think about starting intravenous corticosteroids. The appropriate dose is 40 to 60 milligrams of the equivalent of methylprednisolone IV. And the reason we don't do higher is actually it was a very nice meta-regression that was published almost 20 years ago now that demonstrated that the risk of colectomy was no different when you had 40 milligrams per day versus up to over 100 milligrams. And so you can see that middle line here is pretty steady throughout, regardless of the dose. So that's why we typically recommend no more than 60 milligrams, and maybe 40 milligrams is reasonable because that was the lower end of what was studied here. The good news is that with corticosteroid treatment, up to 2/3 of ulcerative colitis patients and almost entirely 80 to 90% of Crohn's patients will respond adequately to IV corticosteroids in the short term. However, for the unlucky group that do not, we do need to think about rescue therapy, which is a treatment given for our non-corticosteroid responsive patients. When we think about rescue therapy, we think about, in some ways, rescuing these patients from needing surgery. And we have a number of advanced therapeutics that we can use in this role. In order to be ready to give rescue therapy to patients who may have ultimately end up failing corticosteroids, we do need to do some preparation, which is why even if we think there's a good chance they're going to respond to steroids, we can wait on getting ready for rescue therapy. This can actually significantly delay their care. And so because of the properties of some of our rescue therapies, such as cyclosporin and infliximab, we do want to make sure that the tuberculosis status, hepatitis B serologies, and a patient weight are obtained early, because the turnaround time for some of these studies can be significant and can actually preclude us from being able to start rescue therapy, and therefore extending the patient's length of stay. Another day one thing that I want that we'll need to focus on is preventing complications. So reviewing the medication list, in particular looking for non-steroidal anti-inflammatory drugs, opiates and anticholinergic medications, and making sure that venous thromboembolism prophylaxis is not only ordered, but also offered to the patient and delivered. Often patients who are ambulatory and are here for a inflammatory bowel disease flare may seem like they are not necessarily someone who's at particularly high risk of VTE, but we do know that the baseline risk of VTE for outpatients with inflammatory bowel disease is about twofold. And in the hospital, their baseline risk for VTE increases to about eightfold. So this is very important to not only make sure that we've done our part to order it, but that it's being offered at the bedside and that the patient is accepting it. So there is a lot of material to go through for this day one and subsequently to ensure that we're following up on all of these things. And this is obviously small and meant to be crowded because there's a lot that we have to cover. But we did develop a inpatient ulcerative colitis protocol and daily checklist, and we actually incorporated this into an Epic compatible SmartNote that's available, as well as an order set that has a set of bundled orders, both for admission and for daily ordering of labs. The idea is that utilizing a standardized template like this actually can improve adherence to these quality metrics as opposed to just relying on our teams to remember them day in and day out. And so my colleague, Dr. McConnell, and I, when we were actually in fellowship, put together this protocol and studied our adherence to it. And what we were able to see is that our adherence to C. difficile testing was performed 100% of the time. VTE prophylaxis ordering increased up to 100% after this intervention, and that we were able to significantly reduce the daily dose of oral morphine equivalents for patients that were hospitalized with ulcerative colitis. And so I think this really illustrates the value of templates and checklists to be able to provide high quality care and make sure that we're able to execute on the myriad of things that are required for high quality care delivery. The next thing that I think is probably the big bugaboo for managing these patients who are hospitalized, since I mentioned opioids should be avoided, NSAIDs should be avoided. Well, what does that leave us with? And these patients have pain. It's incredibly common for patients to have uncontrolled pain when they're hospitalized with an IBD flare. And the kind of old mantra is that the best way to treat pain is to treat the inflammation, but that sometimes takes time and is easier said than done at other times. The reason why we are very opposed to really trying to leverage the use of opiates for pain control is that it can precipitate toxic megacolon. It can also mask symptoms because opiates can decrease bowel frequency, decrease pain scores that we're actually using as objective markers to measure patients' progress throughout the hospital stay. And then also the risk of dependence and subsequent morbidity and mortality associated with discharge opiate prescriptions, which we also have shown that even for patients who are opiate naive coming into the hospital receiving opiates, they're much more likely to leave with an opiate prescription and also have persistence with that. So this is an opportunity for us to intervene and try to minimize opiate exposure, both in the hospitalization, but subsequently long-term. There have been a number of studies that have looked at educational interventions for both the patients and the providers around decreasing opiate prescribing to help patients understand the risk, providers understand the risk, and understand alternative treatment modalities. But again, easier said than done if the patient in front of you is reporting high pain scores and really feeling limited in our ability to treat it. I found this actually to be a very thought-provoking small study that was published out of Cedars-Sinai a couple of years ago, which looked at the use of a proactive analgesic protocol. And so what it did is it was looked at 33 hospitalized patients and assessed their pain score at baseline. And based on their pain score, assigned them to one of these 3 different proactive or prophylactic pain management regimens that included acetaminophen, gabapentin, and then as needed benzodiazepines, as well as a plan for breakthrough pain with the idea of minimizing opiate exposure by starting first with tramadol as a partial opiate agonist, and then looking to other IV opiates if needed for poorly controlled pain. And what this ended up doing with this small group is that folks were either randomized to receive this proactive pain protocol versus usual care, and opioid use was significantly less with this proactive management group. And they had similar pain scores as well. And that the group that was on the proactive analgesic protocol actually had an increased amount of physical activity. They were able to get out of bed and get moving. So their step count was significantly higher as well. There was no difference in length of stay, readmission. It was too small probably to look meaningfully at colectomy rates, but I thought that this was really thought-provoking as a way of being kind of proactive and talking about pain on the outset, not withholding opiates altogether, but being able to have a structured protocol that can ultimately decrease opiate consumption, increase activity without any meaningful change in other outcomes like pain control or hospital course. The next best practices I did want to focus on is nutrition. And so this is also an area that I feel very passionate about. I feel so badly for our poor patients that end up being on NPO orders for a long time. And so really we should be offering regular diet to patients unless that diet is not tolerated. So of course, if they have a complete bowel obstruction, we are going to be following that protocol. But we shouldn't be withholding food just because we think that they're having a flare. It should really be driven by the patient and what they feel up to eating. When patients with inflammatory bowel disease are hospitalized, iatrogenic malnutrition is quite common, and up to almost half of patients will have unjustified NPO or clear liquid diet ordered. And these patients are already coming in quite malnourished to begin with because of their underlying disease. So adding restrictions to our diet orders is only worsening that. I want to make a big plug that you can actually keep. If you're worried, okay, well, this patient is coming in and it's, they're going to need a flexible sigmoidoscopy. Maybe they'll need some anesthesia. We want to keep them NPO at midnight. But according to the American Society of Anesthesiology, you can have clear liquids up to 2 hours before anesthesia. And so this is a way to allow at least some degree of nutrition and hydration to be delivered to patients while awaiting the GI consultation or awaiting a decision about whether this patient is going to undergo an endoscopic procedure. Additional best practices from a nutrition standpoint include monitoring or replacing micronutrient deficiencies. So that's why I do recommend screening for all of these micronutrient deficiencies on day one, things like vitamin D, B12, and iron. And then also getting the nutritionist involved as well. As I mentioned, malnutrition is incredibly common in this patient population to begin with. And so having additional guidance about what nutritional supplements they should be taking or other ways of eating that might be helpful for them to be able to have the greatest variety of foods without exacerbating their underlying disease. One thing that often comes up as well, maybe we should just put these patients on a low fiber diet, a low residue diet. And I think the tide is really turning on that as well, with the thought that prolonged low fiber diet for patients sometimes will be told to be on a low fiber diet when they come in for a flare, and then they just continue it for years on end because they're told that's what they are supposed to be eating. And the truth of the matter is that's probably to their detriment because low fiber diets we know can worsen dysbiosis, can increase intestinal permeability and promote mucosal inflammation. And so these three things we are certainly wanting to avoid in our patients with inflammatory bowel disease. And so I really do want to, in our guidelines that were published last year in gastro, that we're making recommendations for nutrition, really the idea is to focus on texture and consistency rather than the absolute fiber content itself. So for example, soluble fiber or something that's blenderized or cooked may have a high fiber content, but ultimately will not be as aggravating to an inflamed gut. And so this way, patients don't have to just be on a sort of rice and potatoes type of diet in order to subsist and continue through, but they should be able to continue to get a wide variety of nutrients that way. In terms of our goals for discharge, so the standard sort of recommended goals to be thinking about are manageable bowel frequency and pain, minimal rectal bleeding, if this is for ulcerative colitis flare, ability to tolerate oral nutrition and medications, adequate pain control, and that resolution of sepsis physiology that brought them in the first place. A question that had always piqued my interest when I was in training and in early faculty is really, do we need to monitor these patients in the hospital on oral corticosteroids? So if you look at some of the protocols, for example, at University of Michigan, they very clearly state that part of the sort of standard of care is to monitor patients for 24 hours in the hospital after they've transitioned from IV corticosteroids to oral corticosteroids, just to make sure they don't slide backwards. Maybe there's something about the IV corticosteroids. But I couldn't find anywhere in the literature where they actually back this up, that this is a practice that prevents colectomy or prevents relapse or prevents hospital readmissions down the line. And although our group of patients that we had here is small, I looked at this with a medical student and resident here, trying to understand what the incidence of transition failure, meaning someone goes on IV corticosteroids to oral corticosteroids, and then either in that same hospitalization gets transitioned back because they were not doing well clinically, or end up being readmitted in the next 30 days. And what we can see here is that of the 159 hospitalizations that we had over our study period over a couple of years, that the incidence overall was quite low, it was about 8%. And that patients who we kind of had that spidey sense about, that we did say, you know what, we should actually watch you a little bit longer. We should really keep you here for more than 24 hours. That group was the one that definitely had the higher rate of transition failure. So I think that this argues that we can probably safely either monitor these patients not at all, just transition them out without any oral steroid challenge in the hospital, and that way can shorten their length of stay in the hospital, but also be able to open up hospital bed and diminish our use of hospital resources for these patients who often spend 6, 7, 8, 9, 10 days in the hospital. So this will definitely require a multi-center study to really look at this question specifically, but I think that the data from our center here does demonstrate that there's a role for the right patient to just be sent out of the hospital if we think they're relatively low risk for steroid failure transition. So for those, we talked a lot about just sort of the overall arc and trajectory for patients who might overall respond to corticosteroids and making sure we provide high quality care. But there is definitely a subset, about a third of ulcerative colitis patients and 10 to 20% of Crohn's patients who are corticosteroid refractory. And so we want to identify who these patients are early so that we can determine who's at risk for colectomy or who would be a good candidate for rescue therapy or advanced therapies. So in ulcerative colitis, there are a number of different scoring scales that are used. I think probably the two most widely used ones are the Ho index and the Travis index. And basically what they're looking at is the number of bowel movements and then other signs of inflammation, whether it's hypoalbuminemia or C-reactive protein. And if they kind of meet criteria for being high risk for steroid failure at day 3 of the hospitalization, then it's recommended to initiate rescue therapy. And so for rescue therapy, we think about this as a steroid-sparing agent to manage severe fulminant colitis or enterocolitis in an effort to avoid colectomy or surgical intervention. And traditionally, those the two most common used agents were cyclosporin and infliximab. At UCSF, we don't have the institutional expertise with cyclosporin at this point in time, and so infliximab is pretty universally used. But I did want to just review cyclosporin and its role because there are some centers across the country that still do use cyclosporin. Cyclosporin is a calcineurin inhibitor, and it was our original rescue therapy for acute severe ulcerative colitis refractory to corticosteroids. It was really the cornerstone of rescue therapy until anti-TNFs came onto the scene in the late 90s, early 2000s. The initial dosing is a 2 milligram per kilogram day infusion, and that's why that weight is also important to get on day 1 or 2 so that you're ready to go and can set the infusion up with constant monitoring to make sure that a trough level of 150 to 250 nanograms per milliliter is reached. The response rates are quite excellent. Short and long-term responses were about 63% and 48% in the original studies from the 1990s. And so it was, early on was a very appealing drug to use to help spare people from colectomy. Often people would then be bridged to oral cyclosporin as well as a different agent that had fewer toxicities for maintenance, such as azathioprine. But as I mentioned, and infliximab, which is an anti-tumor necrosis factor monoclonal antibody that was FDA approved in 1998, has really supplanted cyclosporin in most centers. And since the early 2000s, it really has been the cornerstone. And the response rates for acute severe ulcerative colitis range from anywhere to 50 to 83%, depending on the study that you're looking at. So to answer the question about, well, why did infliximab supplant cyclosporin? There was a really nice head-to-head trial called the SISIF trial that was published about a little more than a decade ago, comparing cyclosporin versus infliximab. And what we can see is that the length of stay for infliximab is lower for patients who are treated with infliximab, and that the associated costs, although the drug costs themselves were much greater for infliximab, the overall cost because of the shorter hospital stay was less overall for infliximab, and that the outcomes in terms of risk of colectomy were identical. And so because of that, infliximab has really kind of supplanted cyclosporin. And so I'm going to focus a little bit on some of the questions and controversies related to infliximab and how we provide it in the hospital. So with infliximab, the standard dose that we think about is a 5 milligram per kilogram dose that to start, but we do worry that that may not be sufficient. And so patients with acute severe ulcerative colitis have a really high inflammatory burden, and they are known to have accelerated clearance and fecal loss of infliximab. If you look at the amount of infliximab drug in the stool of patients who are hospitalized and receive a dose of infliximab, you can actually predict failure based on how much infliximab is in the stool. If there's a lot in the stool, it means it's just getting wasted. It's not circulating in the bloodstream and staying present to be able to diminish the inflammation on a longer term basis. Additionally, we know that low serum albumin, which is frequently observed in acute severe ulcerative colitis and in Crohn's flares as well, is associated with low serum infliximab levels and a non-response to infliximab. So we know all these, for all these reasons, these are not just your ambulatory patients walking into the infusion center needing a standard dose. So there was a lot of enthusiasm. Well, why not give more? If 5 milligrams is good, why isn't 10 milligrams better, in terms of dosing? And so, although this is, on a smaller scale, basically what this is, the take home is that accelerated dosing versus standard dosing, when looked at it in this meta-analysis here, really was not statistically significantly different in terms of the treatment regimen. And so there had been a kind of pushback, maybe, although the practice had been that people really liked the idea of accelerated dosing, maybe there really isn't enough to back it up. And the truth of the matter is that if you look at US providers, that many of them would give an initial dose of 5 milligrams per kilogram, and that would be it. But a good number, up to a third of patients, would do some kind of a third of providers would do accelerated dosing, despite there not being the greatest evidence base for it. And in Spain, there was a nationwide clinical practice survey that demonstrated that more than half of providers did an initial dose higher than 5 milligrams per kilogram for the initial dose. So I think in a lot of ways, this higher dose, accelerated dosing, was treating us as the providers rather than the patients in terms of having them receive additional benefit. So even though there was already sort of this idea that accelerated dosing didn't seem to make a difference, it hadn't really impacted clinical practice. And so there has been ongoing renewed interest in really trying to answer this question. And so most recently, this year, a nice study was released from 13 Australian tertiary hospitals, and they randomly assigned patients to receive 10 milligrams per kilogram versus 5 milligrams per kilogram. And basically, the result of the study demonstrated that there was no significant difference in clinical response or time to clinical response with accelerated versus standard dosing. So I think that really helped people feel, okay, we need to really just stick with our standard dosing. There really doesn't seem to be a blanket policy that all these patients are really sick and we should be doing more for them just because we think that they need it. But still, there was this kind of feeling, well, maybe there's a subpopulation that really should have accelerated dosing. And so this is actually just an abstract that came out of ECHO, one of our European IBD meeting from the spring, that looked at this idea of personalized dosing for infliximab, looking specifically at things like low albumin levels, disease severity. And the primary endpoint was a composite of clinical response and endoscopic response, but which did not meet the primary endpoint for this study when they looked at comparing personalized dosing versus standard dosing. But the difference in clinical response did meet statistical significance. And you can see numerically that it does seem to potentially improve clinical response as well. So maybe there will be a subgroup, or we'll figure out a scoring system to identify if patients do need accelerated dosing. But at this point, it seems like there's increasing evidence that really should be reigning in our practices around being more diligent, offering just one standard dose of infliximab for these patients. Another question that will often come up, and we're thinking about rescue therapy specifically, is, well, if this patient is likely to go to colectomy anyway, should we be even exposing them to the immunosuppressive effects of the rescue therapy? And so, I think that this was a nice comparison study looking at IV steroids, cyclosporin plus IV steroids, and infliximab plus IV steroids, and really demonstrating that infectious complications and non-infectious complications really were certainly not significantly higher, and if anything, were better in the advanced rescue therapy groups compared to IV steroids alone. So in that case, I think we can feel confident that we're not doing our patients harm by providing rescue therapy if they do ultimately end up going to colectomy anyway. So we're starting to kind of blend into some of these areas of controversy, but I did want to spend some time now looking specifically at questions that are new and thought-provoking and how we can manage these patients, because what I've sort of reviewed so far is really our standard of care. And so one of the first questions that comes up is, are there alternatives to infliximab for rescue therapy? Infliximab and cyclosporin are not universally protective against colectomy. Many patients that have come through the hospital have already been exposed to infliximab. And so this is where we now get to look at our, medicine cabinet of all these new drugs that have been approved, and think about if we can position any of these to be the new or next rescue therapy for patients who either have not been on infliximab before, or maybe just would be better overall. And so this kind of movement started when tofacitinib was approved by the FDA for ulcerative colitis about a little more than 5 years ago. And tofacitinib is an oral small molecule Janus kinase or JAK inhibitor, approved for induction and maintenance for moderate to severe UC. And why we started thinking about this is that it's rapidly absorbed. It reaches its peak plasma concentration within an hour. And in the clinical trials, clinical response was seen within 72 hours. So it was a very quick turnaround compared to some of the other biologics that have been popping up. Vedolizumab could take, taking several weeks, for example. And so this was very compelling. And then lastly, because tofacitinib and the Janus kinase inhibitors are small molecules, they're less susceptible to drug loss that we can see with medications like infliximab, because they don't rely on albumin to be bound and to be circulated. So this was another reason people got excited. And then lastly, because it's a daily medication or a twice daily medication, the pharmacokinetics are favorable, particularly if someone does end up needing to go to colectomy or have surgery, that we can actually just stop it and it'll be out of the system much more quickly than something like infliximab. And so the initial case series that were published, and we actually published our experience on this as well in 2021, but the initial most robust case series that came out of the University of Michigan demonstrated that it was actually quite effective as a first-line therapy, no steroids at all, 86% effective as a second-line therapy in combination with IV steroids, and 2/3 of patients were colectomy-free after failing IV corticosteroids and infliximab. And that overall, the colectomy-free survival was about 71%. So this is a subset of patients who are probably sicker than our general cohort of patients who are just coming in for IV corticosteroids. So people got really excited about this. We did start to use this in the hospital here at UCSF and in other centers as a sort of third-line therapy for patients who had already been exposed to infliximab and were not doing well on IV corticosteroids. But then the newest kid on the block, upadacitinib, which is a selective Janus kinase inhibitor, was approved for moderate to severe ulcerative colitis and Crohn's disease now a couple of years ago, about 3 years ago. And it is kind of the new and improved cousin in a lot of ways to tofacitinib. Similarly, it provides rapid symptom relief and mucosal healing. It's also a small molecule, doesn't require albumin binding, as well as it's a daily medication that can be cleared quickly with drug cessation. And so what we looked at is, what was looked at in this systematic review, kind of compiling all the small case series of patients who had used upadacitinib for steroid refractory acute severe ulcerative colitis. They saw 55 patients. And there were, the colectomy rate was very low, it was 16%, lower than probably any other study I've cited so far today, with low rates of adverse events. Although notably, there were 2 thromboembolic events noted in 55 patients. And that has been a concern with the Janus kinase inhibitors in general, particularly in the rheumatoid arthritis population. There was a black box warning that was subsequently put on the Janus kinase inhibitors because of concern for increased risk of thromboembolic events and cardiovascular events. That has not really been reproduced in the inflammatory bowel disease population, but we do know that IBD is associated with a significant increased risk of VTE. So there is concern these patients are really high risk when they're so inflamed. If we're now giving them upadacitinib, is that increasing their risk for thromboembolic events? And this, I think, although overall is really exciting in terms of the low rates of colectomy for likely a sicker subset of patients, that the low rates of the adverse events overall seem low, but I think warrants further study to determine if there is an impact on thromboembolic events utilizing upadacitinib this way. Another area of interest, both here at UCSF and globally, is the question of, does acute severe IBD really need to be managed in the hospital? If we think about there's a lot that has to happen on day one, but the cadence at which it needs to happen, it's really daily labs, daily IV medication, daily assessment by the hospital medicine and GI team. So maybe that could just be done in the outpatient setting. And this really came up around the COVID pandemic. We started thinking about this. The idea is that we needed to save hospital beds for sicker patients, resource-constrained system. And so is there a way that we can divert patients out of the hospital to get their care pathways done as an outpatient? And then also, understandably, a lot of patients who were getting IV steroids and other immunosuppressants were really nervous about coming into the hospital where there are lots of sick patients with COVID and other infections. And so they much prefer to be home and in their own bubble. And so this question was looked at a multi-center group in the United Kingdom of acute severe ulcerative colitis patients. And they had 3 different types of care pathway. One is the standard inpatient care pathway that we are all familiar with and that we've reviewed today, but also a small number of patients who were managed in an ambulatory fashion from diagnosis, so going to an infusion center or having a home nurse come to deliver medications, draw labs, take vital signs, and do assessment, having telemedicine available for these patients, or a sort of stabilization model and accelerated discharge where patients would be hospitalized, they get all the things that need to happen on day one done, assessed, made sure that they don't have any significant complications, and then are sent home with a sort of treatment plan to get ambulatory care. And with this, they didn't see any significant difference in colectomy or rehospitalization rate in this large multi-center study. I think this made a lot of people nervous because they feel like, well, these are patients that are sick, they're in the hospital, they are 1 second away from having a perforation. But I think by and large, most of these patients could, or many patients could do well with a pathway like this. And so we were interested in looking at this at UCSF as well. And so I put together this pilot study that was born sort of out of the COVID era, looking at a group of 10 patients that we enrolled into what's called the Mosaic Protocol, the management of severe ulcerative colitis with ambulatory IV corticosteroids. And really we're looking at the feasibility of this model as well as other things like safety and patient satisfaction. And we had a control group of 5 patients who were hospitalized that we followed prospectively. In this very small group, of course, because this is just a pilot, there was no colectomy in either group. The rehospitalization rate was similar between the two groups. There was no clear signal that everybody in the ambulatory group ended up needing to come to the hospital. And the overall patient satisfaction by 2 weeks into their treatment course was really no different. Interestingly, though, the kind of day 1, day 2 satisfaction scores for patients who were put into this ambulatory group were actually lower than patients in the hospital. And I think a lot of that may have to do with the fact that, if you're feeling really sick and it's kind of nice to just not have to do your dishes and not have to, take care of all the burdens at home and just have some time to be in the hospital and be taken care of at that point in time. But basically by day 3, the satisfaction scores were very similar throughout the study period. And so this was really exciting, but it was logistically very burdensome to arrange for daily IV infusions, to make sure that labs were reviewed, that there was a provider available to be assessing the patient on a daily basis. There were certain other hurdles like insurance authorizations that become actually increasingly difficult in our complex healthcare system. So although this is something I think that shows a lot of promise and would be able to open up a lot of inpatient beds, at the very least, we could get that expedited inpatient evaluation and then send people home, that it would also require significant investment upfront in terms of logistical support to be able to execute on this. But there is, a lot of hospital at home type programs, and other groups have been looking at various models of how we can best optimize on the fact that a lot of the care for sort of acute severe IBD flares really could potentially be managed in a less intensive setting. One other controversy that I think is less controversial, but this is something that has come up and I think is often in regular practice for folks, is giving patients calcium and vitamin D when they come into the hospital. And what is the data for that? Should we be doing this? So we do know that calcium D deficiency is linked to higher IBD activity, relapse risk, and the risk of hospitalization. Adding supplementation of vitamin D for patients who are deficient decreases the hospitalizations, ED visits, steroid use. So we know in an outpatient setting that we are checking vitamin D on all of our patients, making sure we're aggressively replacing it. But there really are no RCTs or really any data at all for patients who are hospitalized or are treated with IV corticosteroids. And so I think ultimately, because it's safe and low cost, we are often offering it to patients because we know of the risks of being on corticosteroids and the increased risk of vitamin deficiencies in patients who are hospitalized, and the purported benefits, probably with very little risk. So I have seen that more universally being prescribed for patients while they're in the hospital, and then to be continued when they're on outpatient corticosteroids doing their taper. But again, no data really to drive this, but I think overall it seems kind of like a low risk practice. The next controversy that often will come up, especially as we're preparing patients for discharge and we're writing out this very long prednisone taper, and we recognize, should we be prescribing pneumocystis jirovecii pneumonia prophylaxis for these patients? We know that PJP prophylaxis is recommended for patients on 20 milligrams of prednisone for more than 4 weeks per ASCO and IDSA guidelines. And so that's often where this gets triggered. We see, oh, wow, we're writing for a lot of weeks of prednisone that's more than 20 milligrams. Maybe we should think about this. However, the risk of developing PJP in patients with IBD is incredibly low. This was one kind of systematic review cited it at 0.07%. And in fact, it may be lower because I think there's probably a lot of reporting bias in some of the case series that have gotten added to the literature. But what they did notice is that the risk factors for developing PJP and IBD did seem to fall for patients who are elderly, who were had lymphopenia. And so perhaps thinking about tailoring a PJP prophylaxis regimen for patients who might be higher risk would be appropriate. There is some concern that providing unnecessary antibiotics to patients with IBD may upset the gut microbiome and cause additional dysbiosis that may further drive inflammation and instability of their disease. And so I think we have to think a little bit carefully about whether it's appropriate or is going to provide harm or benefit for these patients, given the low risk of PJP, but also, I guess, a very small amount of antibiotics is potentially not going to have a big impact either. So this definitely, I think, requires some further study, ideally some kind of randomized trial to look at, but it would require a huge number of patients to be randomized given the very low incidence of PJP in this population. So we may not know, and we may just have to continue to try to do our best to guess who we should be taking the risk in prophylaxing and not. So that is the kind of wrap up of the kind of whirlwind review of the state of affairs for inflammatory bowel disease and updates in hospitalized IBD patients. So just as a review, the standard of care now for hospitalized IBD patients means assessing the disease response, ensuring appropriate diagnostic evaluation is performed with the appropriate lab tests, stool tests, appropriate imaging tests, and endoscopy, preparing for advanced rescue therapy that will potentially be a rate limiting step for patients when they're in the hospital, ensuring appropriate VTE prophylaxis, thinking about different strategies for pain management, including potentially proactive pain management protocols, nutrition, avoiding iatrogenic malnutrition, and ensuring higher fiber content if tolerated, and making sure surgery gets involved when appropriate. Areas for future study include these pain management protocols. Is there a role for inpatient pain service and then proactive pain protocols, ketamine drips, anything like that? Optimal dosing of infliximab, the roles of JAK inhibitors as the new rescue therapy, potentially as first line, as second line, or as third line. Is there a role for ambulatory care for acute severe ulcerative colitis or other Crohn's disease flares? And whether we should be providing calcium and vitamin D for patients or PJP prophylaxis for these patients. And with that, I want to thank everybody for their attention and welcome any questions.
Thank you. That was great. I'd love to start with a couple questions or comments of my own, and then I'll throw it out to the audience here. I thought it was really great how you gave this super helpful framework in terms of a big picture view as somebody who takes care of patients with IBD on the hospital medicine service, kind of like, you usually are here for about a week. These are the things we do up front, and just thought that was like a really great way to convey that info to us. So thank you. Other great pearls related to the PCP pneumonia prophylaxis. So my ID background, it's sort of like a reflex thing to think about Bactrim, but not necessarily something that's needed and could do harm, like you're talking about with the dysbiosis. One question I had was just if you could extrapolate a little bit more on like when surgery gets involved in these cases, because it feels kind of heterogeneous. Mm-hmm. When that is recommended.
And I apologize, I actually had a slide that somehow I think dropped off on this, but basically the way we think about it is there are various time points in the hospitalization where surgical intervention is appropriate. If you ask any colorectal surgeon, they will say the best time to consult us is now, because I think the last thing that they want is there to be an emergent indication for surgery, and that they are meeting the patient for the first time wheeling into the operating room, or essentially wheeling out of the CAT scan where they have a perforation. So the idea is to be able to have those conversations early, to talk about stoma care, for example, so patients understand and can kind of have surgery demystified, I think is really important. On the flip side, definitely having taken care of a lot of these patients who are coming in, it's their first time ever being in the hospital before, for example, and to have a surgeon come in and tell them, all right, and then this is what an ileostomy is, and this, that, and the other, can be a little bit too much of a psychological burden. So it ends up being, I think, a little bit patient dependent, but I think the overall principle is erring on getting them involved a little earlier than you think they might be needed, so that there is time for those conversations. And I think being really upfront that this is not about, we think that you need surgery, but just we want you to have the opportunity to ask questions and learn and just know what all your treatment options basically are. And so in terms of when to get involved, so certainly if someone walks in on that day one and they have toxic megacolon, a perforation, et cetera, surgery needs to be involved at that moment, right? But then throughout the hospital stay, as I mentioned, kind of people are going through day 3 to 7 and beyond, that if patients are starting to move towards rescue therapy and they really have had no response with IV corticosteroids, at that sort of day 3 to 7 mark, I think it's an appropriate time to get the surgeon involved. For patients who maybe have a high level of anxiety that we think that could be provocative, and it's going to take a lot of nudging, I think you can make a tailored approach. But really, once you get past day 7 to 10, the increased risk of delaying surgery is really high. It increases mortality, increases wound healing, and poor rates of wound healing. So overall, the idea is that your window is really to get them involved in that sort of second half of their expected hospitalization.
Super helpful. I have some more questions, but I'll table them so others in the audience can take part as well. I'll start with you, Sam.
Thanks. Hi, Sarah. Fantastic talk. I've always been fascinated by this idea that in painful IBD flares that you should not use opioids or NSAIDs for pain control. And that's something I've done and always struggle with a little bit. And I'm just curious if you could talk a little bit more about like your approach to patients when they're in pain with flares, around like, are you trying to coach them that, some pain may be part of the process, but that the tools we have usually are going to be counterproductive? Or just curious for your approach.
Yes, no, and I think this really is the hardest part, I think, for being on the provider side, is confronting those patients who really have uncontrolled pain. And certainly for things like, I think there are big asterisks to the no opiates ever that are, scattered throughout. But, certainly patients who have a penetrating complication like, a perianal abscess or intra-abdominal abscess, that's kind of a different pathway where we think opiates would be appropriate for pain management at that in that group. But for the sort of true sort of enterocolitis type of flare where they are having a lot of pain, that is definitely a part of it. I think that it's multifocal or sorry, multi-pronged in terms of the approach to take. One is obviously trying to capitalize on the pharmacologic treatments that we do have available, which are limited, I think is important to recognize, but then also to coach the patients about, and that's where these educational initiatives in terms of having patients really understand, if I take, this IV Dilaudid or this, oxycodone, that I actually may be setting myself up for things to be worse. It's sort of like short-term relief for a long-term detriment, and trying to help patients understand that, sort of see the big picture. But of course, in that, a moment is fraught. And then I am always a big advocate also of early involvement of, if you have the luxury, which we do here, of having a pain management consultation, getting them involved early for multimodal pain management, whether it's more advanced therapies or just, I think, other, adding other things like mindfulness and gut-directed hypnotherapy, and, there are a whole slew of different techniques that can be used as well. But it's still a big challenge. And I think something that I would love to continue to work on and think about how we can best protocolize pain management so that it's not this kind of constant tug of war between the patients and the providers and wanting to heal the suffering, and tend to the suffering that's right in front of you, but also looking at the big picture.
Thanks, Sarah. That was a great talk. I learned a lot. And there are a lot of parallels between what you shared here and what we do as rheumatologists. And I think there are things that I'm taking away. I specifically have questions about how you implement and use the quality and safety checklist. I love that. And I'm just wondering, do you as the consulting services use it? Do you share it with the primary team? Kind of what's the workflow for using
that? No. So, and we have, we basically as the consultants have this smart phrase that we can put into our notes. There's varying efficiencies in terms of how detailed you want to go through. So the original iteration of this was a physical checklist where you had a drop-down menu for each of those different points about, I've checked the bar for VTE prophylaxis. Yes, no. I, checked that there are no opiates. Yes, no. So it took a lot of time to get through, but obviously physically made the consultants go through and review each of those things. It's now evolved for our busy fellows to be able to sort of condense it more into sort of a recommendation checklist. And the idea is it should be reminding them to go through all those steps to review the medication administration record, to be able to, ensure that, labs that were pending are being followed up on, et cetera. The PPD has been placed. But that ended up being sort of the templated within the consultant note is how that was one aspect of the intervention. And then the other was actually having a bundled order set that's available for the admitting teams. I think it's a little bit hard with so many rotating teams and different providers, as well as the frequency at which patients are caring for, or the frequency at which providers are caring for patients with IBD is not so frequent that they're like, aha, this is the MI, order set. I've used this a million times on my cardiology rotation. But, certainly it is available. It's still in our, built into Epic that is there to ensure that all those labs and other studies are ordered. So those, I think, were the two main things. We also, though, have data core support. We actually have a dashboard, an inpatient dashboard that will allow us to track over time what our metrics are, how good is our VTE prophylaxis administration for our patients hospitalized with IBD, and we can filter that by service. So if we don't want to look at patients on the colorectal surgery service, we can just look at hospital medicine at Parnassus, for example. So that also allows anybody who's interested, like myself, to be able to follow that over time to see, okay, well, how are we doing on discharge appointments? How are we doing on VTE prophylaxis, opiate prescribing, et cetera, and kind of can follow our metrics from that. So those are just some of the tools that we've been using.
Great. What other questions are there? Looks like we have a couple other minutes. Yeah, great.
Hello. I was wondering, I know patients, outpatient, can often go through many different types of therapies and often have flare-ups during those different treatments. Do you find that, and needing to switch medications, do you find that patients who have had these multiple like failed medications are more likely to end up needing the rescue therapy? Or is it just any patient has kind of an equal probability of needing that additional therapy?
It's a great question. And so we see this in a lot of the clinical trials, even for, the response rates for patients, we often say the best biologic is your first biologic. And so anytime a patient is now refractory to multiple treatments, we know that their disease in general is just it can be more refractory. So if someone is coming in, having been on a mesalamine monotherapy with their first acute severe ulcerative colitis flare versus someone who's come in, who's been on multiple anti-TNF therapies and vedolizumab and been on an IL-23 agent already, they're much more likely to not respond to IV corticosteroids alone and are more likely to need rescue therapy or are also at higher risk of colectomy. The only caveat I will mention, though, is that patients are presenting with kind of like their index presentation of ulcerative colitis or Crohn's is this fulminant enterocolitis, that they actually are at the highest risk for needing surgical intervention and failing everything, because it just demonstrates that the phenotype that they have is very aggressive and often is more difficult to control with medicine.
Great. And speaking of refractoriness, did I understand correctly? It sounded like patients with UC are significantly less likely to respond to IV steroids. And why is that?
It's a good question. Generally speaking, and this can be, based on people's experience, probably can back this up as well, that the number of patients who are hospitalized for severe Crohn's complications, it's much less that enterocolitis phenotype and much more some of the other complications, the penetrating complications, abscesses, strictures, et cetera. And ulcerative colitis, when patients are hospitalized, it's very homogenous. There hasn't been a great, sort of hypothesis about the difference in why the sort of immune burden in some ways for ulcerative colitis is so much greater, that just leads to this much higher inflammatory response with regard to like an enterocolitis type of flare. Typically that more severe inflammation for Crohn's, because it's that transmural nature, is going to be distributing or disseminating sort of down through the bowel wall. So we're maybe less likely to see that, whereas everything in ulcerative colitis is, very superficial mucosal layer. But there's not been a good explanation for why the phenotypes, especially in this kind of severe spectrum, are greater for ulcerative colitis in terms of the enterocolitis picture.
Great. One more question here.
Yeah.
Can you just repeat it?
Yeah, absolutely. So the question is, timing of starting IV corticosteroids. So should that be, after we've gotten all the GI-PCR and the C. diff back? Should that be after we've gotten our scope to really understand what what it looks like? Is it really truly severe disease or not? And so I guess there are sort of two pieces for that. And now I'm feeling a little sheepish because I'm overdue on publishing my results from looking actually at our IBD core at this very question, because I think this does come up around whether we need, specifically around C. diff. There had been kind of this adage like, oh, we have to wait for the C. diff because, oh my goodness, that would be terrible if we gave somebody coming in with fulminant C. diff a whopping dose of IV corticosteroids, just make things worse. And so we're looking currently at essentially the rates of C. diff in that setting. Like, well, how often does that actually happen that someone comes in and we think that it's an IBD flare and it turns out that it's actually a C. diff flare? Overall, the rates I think generally are pretty low, but C. diff does come back pretty quickly. So it ends up being this tug of war in terms of, do we just do that on day one, get it all started? And I think we're seeing that probably unless patients have a history of C. diff, this is kind of the preliminary analysis. If patients have a history of C. diff or other significant risk factors, including sort of dual immunosuppression, like dual biologic therapy, for example, that the likelihood of there being C. diff is low, and then even less so in terms of impact on length of stay, worsening disease, that treating with a dose of IV steroids and then pulling it back does not seem to be harmful. So from the stool standpoint, at least that's where the data is looking, but I don't have the final results yet. So that's conjecture at this moment. And then in terms of the endoscopic evaluation, certainly for CMV, IV steroids aren't going to worsen that, aren't going to resolve that to mask that. So we would still see CMV if it was there. And the challenge is that the turnaround time for getting CMV staining and all of that back from the pathologist, we're already now into day 3 or day 4 of the hospital stay. So it doesn't really make sense to wait for that pathology to come back and confirm that there's no CMV before offering treatment. The question would be, if you gave corticosteroids off the bat and then you took them for a flexible sigmoidoscopy 2 days later and it looked perfect and pristine, well, was this really a flare or not? And I think would then depend on the clinical context. I think that would be pretty unusual that you would have that scenario where you give someone IV steroids and it melts their colitis away so cleanly that they don't have any active disease. And if that were the case, then I think you just put them on a rapid steroid taper, say, okay, maybe you were steroid responsive, or maybe this wasn't IBD after all. And I think ultimately just thinking about ways that we're not delaying care for these patients is what's shifted our approaches a little bit that way.
Great. Thank you. That was awesome. Thanks to everyone for attending, and I'll see you next week.
Great. Thank you, everybody.